Welcome to the Deep Dive, your shortcut to mastering complex source material. Today, we're plunging right into the body's essential oxygen delivery system. It's a huge topic, and it's all about what we call perfusion.
Yeah, and it's so fundamental. Our sources really frame it well.
Yeah.
Perfusion isn't just, the heart pumping.
Right.
It's the continuous, seamless delivery of oxygenated blood to every single cell in the body. It means the heart and lungs have to work together perfectly.
It's the body's life-giving supply chain, quite literally.
Exactly. And to really get it, we have to look at what happens when that supply chain breaks. So for our deep dive today, our mission is to analyze some specific congenital heart defects.
These are failures that happen right after birth. Yeah.
Yes, when the system doesn't transition correctly. And we're going to categorize them by how they mess with blood flow. We're talking the three major types you see in pediatric cardiology: increased flow, decreased flow, and then obstructive defects.
That categorization seems like it's everything.
Yeah.
Because the problems all stem from one single, chaotic event. The switch from being a fetus to breathing air. In the womb, the whole circulatory system is built to bypass the lungs. They're not being used yet.
That is the crux of it. Fetal circulation is set up to shunt or divert blood away from the lungs.
And the problem starts when those shunts, those temporary pathways, don't close after birth.
Precisely. When they stay open, you get blood flowing where it shouldn't. And often that means it's just flooding the lungs with far too much volume.
Which brings us right to our first category. Increased pulmonary blood flow. So these are the leaks.
The leaks, yeah. Things like atrial septal defect, ASD, or ventricular septal defect, VSD, and patent ductus arteriosus, PDA.
And in all of these, the blood is shunting from the high-pressure left side of the heart back to the low-pressure right side.
Right back into the lungs, overloading them.
Okay, so let's start with the PDA, the patent ductus arteriosus. Our sources say its physical findings are really unique.
They're so distinct. A PDA is basically an open artery that connects the aorta and the pulmonary artery. And because the aorta has such high pressure, it's constantly dumping blood into the lower pressure pulmonary circuit.
So it's like a drain on the whole system.
It is a constant drain.
So what does that do to, the patient's pulses?
Well, it creates the absolute classic presentation. You get full, bounding peripheral pulses and a really widened pulse pressure.
Why widen?
Because blood is running off into the lungs during diastole when the heart is relaxed. So your diastolic pressure just plummets.
Okay, so the gap between the high and low numbers gets huge.
Exactly. That wide pressure difference and those bounding pulses, that's your dead giveaway for a PDA.
That's the kind of nugget we need. And with all that extra blood in the lungs, I'm guessing things like pneumonia are a big risk.
A huge risk. Pneumonia, endocarditis, all of it. Now, for treatments, sometimes it's just a wait-and-see approach.
And if that doesn't work?
Then they often use IV indomethacin. And the key thing to know here is that indomethacin is a prostaglandin inhibitor. Prostaglandins are what keep the ductus open in the womb.
So you're basically using a chemical to force it shut.
You are.
Yeah.
And if that fails, then surgery is the next step.
Okay, let's group the next two together. The atrial and ventricular septal defects, ASD and VSD. The sources say they can be pretty quiet at first.
Yeah, often asymptomatic. Sometimes they aren't even diagnosed until preschool, but they present very differently depending on where that leak is.
So let's talk VSD first.
Yeah.
The hole between the ventricles, that's a huge pressure difference.
Massive. So if you're looking for the key signs, think about extreme effort. You see the signs of congestive heart failure, sure, but the most heartbreaking sign really is the sweating and fatigue during feeding.
Oh, wow.
Yeah, and that leads to poor growth.
That makes so much sense. I mean, just imagine the energy it takes to eat when your heart is already working overtime.
Exactly. The lungs are flooded, so gas exchange is inefficient. They have to breathe faster and harder just to get enough oxygen. It's exhausting.
And the ASD, the hole between the atria?
Often less severe early on. But it carries long-term risks, like hypertension or mitral valve problems down the road. Treatment for both is usually monitoring, then surgery if it's needed.
Okay, so we've covered systems that are too leaky. Let's flip it completely. What happens when blood flow to the lungs is cut off? That brings us to category 2. Decreased pulmonary blood flow.
Right. Now, the mechanism shifts from accidental openings to just pure obstruction. We're talking about things that physically block deoxygenated blood from getting from the right side of the heart to the lungs.
So little or no blood gets oxygenated.
And that has immediate, pretty profound consequences.
And the textbook example here, the one everyone learns, is tetralogy of Fallot.
Oh, gold standard, yep.
So if this is causing critical hypoxia,
Hmm.
what's the single most visible but kind of counterintuitive thing these kids do to compensate?
That is the critical detail. Of
Ugh.
course, you see the cyanosis, the bluish skin, and over time you get clubbing of the fingers. But the behavioral finding, it's the squatting or
Right.
pulling their knees to their chest,
Mhm.
especially when they're stressed or trying to exercise.
Okay, but why does squatting help? That seems so
That's
random.
mechanically brilliant. When a child squats, they're kinking the large arteries in their legs.
So it increases pressure in the body.
Exactly. It
No.
increases their systemic vascular resistance. That extra pressure makes it harder for blood to shunt away from the lungs. And, it forces more of that deoxygenated blood through that tight pulmonary artery.
So it's like a self-performed, life-saving physiological hack.
That's a great way to put it. It temporarily improves blood flow to the lungs and eases the cyanosis.
Fascinating. And because of the chronic lack of oxygen, the body tries to compensate in other ways too, right? Like with polycythemia.
Yeah, the body just desperately tries to make more red blood cells to carry what little oxygen is available.
Right.
But that thickens the blood, which, causes its own set of problems later. Ultimately, the fix for TOF is surgery.
Okay. So far, we've hit flow problems to the lungs, either too much or too little. Our final category is a different kind of restriction, obstructive defects.
Right. These are the bottlenecks that happen after the blood is already oxygenated. They
Yeah.
stop it from getting out to the rest of the body.
So the lungs did their job, the blood is ready to go, but the exit is blocked.
Precisely.
Let's look at aortic stenosis. The valve leading out of the heart is narrowed. You said this can be silent, but if you're comparing it to the PDA we talked about, what's the crucial difference in a physical exam?
The pulses. It's an absolute diagnostic contrast
So PDA had the full bounding pulses.
because blood was draining away. Yeah. With aortic stenosis, the outflow from the ventricle is restricted, so you get weak peripheral pulses and, crucially, a narrow pulse pressure.
No easy runoff, but also no easy exit.
Exactly. And in older kids, you start to see the classic symptoms of low output: chest pain, dizziness, syncope,
The heart just can't push enough blood past that blockage to meet demand.
especially during exercise, yeah. The treatment is usually opening it up with the balloon dilation or, eventually, a full valve replacement.
Okay, the other big bottleneck is coarctation of the aorta, or CoA, a narrowing of the main vessel itself.
And this one is the definition of a blockage. Because the aorta is squeezed, blood just backs up. It pools upstream.
Causing congestion back in the lungs, heart failure.
Yep. And symptoms like coughing or swelling in the hands and feet.
So if you only remember one diagnostic tool for CoA, what should it be?
It's so simple. Just palpate the pulses at the same time.
Upper body and lower body.
Yes. You'll feel a dramatic difference. The carotid and brachial pulses above the blockage will be strong, but the femoral pulses below it will be noticeably weaker, often delayed too.
That pulse difference tells you everything.
Instantly. Treatment is similar: angioplasty or surgery to relieve that choke point.
All right, let's pull this all together for you. We've covered the three big failure modes of perfusion. You have the leaks, causing increased flow like PDA and VSD.
Then the obstructions blocking flow to the lungs, decreased flow like tetralogy of Fallot.
And finally, the bottlenecks blocking flow to the body obstructive flow like aortic stenosis and CoA. The whole point of this was to show how specific symptoms, like a widened pulse pressure or getting tired while eating or squatting.
They give you immediate insight into the underlying physiological chaos.
Exactly.
And when you tie it all back to that tricky transition from fetal life, there's a really profound paradox in how we treat these things.
Oh, this is interesting.
Remember how we treat a PDA? We use indomethacin to inhibit prostaglandins and force that fetal structure to close.
Right, because it's causing too much flow. It's a leak we need to plug.
But when you have a newborn with a severe obstructive defect, like aortic stenosis or a bad coarctation, the immediate life-saving treatment is often prostaglandin E1.
Wait, so you're giving the very thing you were trying to block before?
We are administering the very chemical needed to keep that same fetal structure, the PDA, open, on purpose.
So you chemically create the leak from the first category to save a patient in the third category.
Exactly. You temporarily maintain that fetal state to create an emergency bypass for systemic blood flow until a surgeon can fix the real problem.
Yeah.
And that raises a really important question for you to think about.
Okay.
When does a temporary fetal necessity transform into a life-saving escape hatch? And when does it become a life-threatening defect? What does this crazy juxtaposition in treatments really reveal about the chaotic but incredibly adaptive nature of our circulatory system?